Hello, we're going to go ahead and get started. My name is Christian Kalma. I'm a second-year medical student at Creighton University School of Medicine. I'm also part of the coordinating committee, so thank you guys all for being here. I don't know if you know this, but this is our third year having it, and it's grown each and every year, so obviously that wouldn't have been possible without you guys, so thank you so much. So it is my pleasure to introduce Ms. Andrea Sprockett. Ms. Andrea Sprockett had a Spanish and International Studies bachelor's at University of Nebraska-Lincoln and achieved a master's degree in translation from Kent State University and another master's degree in international public health from the University of Sydney. As far as work, Ms. Sprockett was previously the director of global health education at Stanford University and was an analyst at UC San Francisco for social franchising initiatives and health metric development. Currently, she's the chief operating officer of Metrics for Management, which is a nonprofit that works in data collection for low and middle income countries. So without further ado, please welcome Ms. Andrea Sprockett.
I'll get this on and make sure you can hear me. Do I speak here? Is this loud enough? Is it coming through? Okay, great. So I wanted to start with this cartoon. We've maybe all seen the stats of how many times you've been to a website. But this is how we approach data a lot of the times, is we can collect it, it's available, we think we should, but no one really cares about it. This person can't use this information to improve their website or to drive more traffic. And the person who found out that they're the 851st person doesn't care. And so I'm excited to be here today to talk about data for decision making. As Christian introduced, our organization works to help organizations in low and middle income countries to identify, collect, and use data for program decision making. And this is something that's really near and dear to my heart. And I'm especially excited to be back here in Nebraska as a Nebraskan now living in California, to be able to speak to an audience who cares about global health. So Dr. Rudy already beat me to this and did the poll, but I thought it would still be fun to see who is in this room today, so that we can continue to adjust the discussion and the presentation based on who's here. So can I get a sense with raise of hands of how many of you are students? Great, fantastic. How many are faculty? Oh, wonderful. Something else? What are you?
I'm a public health professional and work for an ACU.
Fantastic. I'm happy to have you here. And I saw a hand in the back, too.
I'm an RN and I have nonprofit.
Wonderful. Well, welcome. I'm happy to have you here.
Can you speak up?
Sure. Let's see if we can get this up a little closer. See if that's better. And how many of you care about improving global health outcomes? Hopefully everyone, and that's why we're here today. So what we're going to do is we're going to look at some real-life examples to demonstrate the importance of data for program management. We're going to walk through an example from my own work to discuss a challenge to routinely measure client poverty. And then I'm going to introduce the equity tool. And we're going to do some demos in the process, so there will be some interaction throughout the session. And what I hope that you'll come away from today with is an idea that data is really important to transform health service delivery. And it doesn't have to be time-consuming, it doesn't have to be expensive, and it doesn't have to be strictly academic. Or it doesn't have to be because your funders told you you had to. It can be something that's really meaningful for you, providing service delivery. So I wanted to start with a few examples. The Nature Conservancy has a mission to preserve plant and animal diversity by protecting their habitats. And they do this through donations. So donations allow them to purchase additional acres of land and to protect those acres of land. But, as Harvard biologist E.O. Wilson points out, the rate of extinction of plant and animal diversity is the same as when the dinosaurs were around. So that's pretty substantial still. So we know that protecting habitats does not necessarily protect species diversity, that it's also about being able to connect different islands of land, to be able to have to protect those species. So they're collecting information, but it wasn't a full enough picture to know what they needed to do to better reach their mission. The next example is from my own work. I previously worked with an AmeriCorps program in Northeast Ohio that used AmeriCorps volunteers to improve literacy. So we had 20 different sites across the city that did things like worked on childhood literacy, had after-school tutoring, in-school tutoring, GED programs, financial literacy, health literacy, with the aim of trying to improve literacy across the city in a variety of different ways. But we didn't have a common definition. We didn't have a way to say, this is what we mean by being literate, or this is how we know that we have improved literacy rates. So we let our programs, our 20 different programs, report everything. So we knew we had data on clients served, the number of hours someone spent in a classroom, GEDs completed, pre- and post-test, kindergarten readiness scores. But we still couldn't say, did we actually improve literacy in Northeast Ohio? And so my job was to sort of retrofit a data strategy to this program to be able to say, this program's effective, they're working well, we can learn lessons from them. This program's struggling, what can we do to improve? And after 3 years of doing this, we ultimately had to say, we can't. We can't say that we're improving literacy. And that's what our whole goal was to do. We had all of this data, but it didn't help us to say we're improving literacy. And so we stopped the program in its current iteration. And we changed it, so it's focused on financial literacy. And so now they can measure bank accounts opened and a minimum balance maintained. They're able to look at credit established and credit grown. And they're able to look at budgeting and being able to stick to budgets. Now they have these goals and they're able to say, yes, we're improving financial literacy because we're collecting the data that matters. And then the last program I'll speak about is the African Health Markets for Equity, or the AME program. It's a Gates and DFID funded project, so UK aid, that aims to increase health coverage among the poor. And so 3 years into this 5-year program, they have done a full evaluation of, are we reaching the clients that we think we're reaching? And this is a project that took several months, over 6 months to do as part of the evaluation. It was part of a big $7 million evaluation, so quite expensive to get this data. And they found out they're not serving who they thought they were serving. And so they took this data and they really valued it, and they said, this is great. We know this now. We're 3 years in. What can we do that's different so that we can use this to improve how we're providing services? And so they've done outreach, they've used vouchers, they've used community mobilizers to encourage individuals to come in and seek services. But they won't ultimately know if they're successful for another 2 years when they do that post-project evaluation. And again, it will be similar to that mid-year project evaluation, where it takes several months and it's rather expensive looking at all of the different areas of the AME project. So the question is, what if you could collect data on a routine basis that's inexpensive, that's meaningful to the people running a program, and that you can use to improve your health service delivery? And so that's what we're working on, and that's the example I'm going to walk through today. So we had a group of NGOs come to us and say, we want to measure the wealth of the individuals coming in for services. They all had a core component that they wanted to provide health services to the poor in low and middle income countries. And they wanted to do this because they want to understand where interventions are needed. They want to be able to monitor their program strategies. They want to inform their targeting strategies, such as if they're going to use a voucher, how should they be using those sorts of strategies? They wanted to be able to demonstrate with data that they were effective to their clients coming in for services, to their program leadership, to their donors. And they wanted to be able to understand and improve service delivery. So in the past, what they've done is they've located clinics in low-income neighborhoods. We know that access can be a challenge, and so if you put your clinic in a place where people live, you're more likely to serve the population you're aiming for. They would look at the percentage of clients who qualify for social health insurance, or those who have below poverty line cards, and These are cards that are given out in some countries. It's a rather imperfect system, and both these below poverty line cards and the percentage of clients who qualify for social health insurance are sort of proxies to being able to estimate what a client's wealth is. Or like the AME project, they've done this in a post-project evaluation. Or they just didn't measure. We've had programs tell us, we think we are doing it, but we don't actually know. So we want to be able to routinely measure real-time service provision to know, are we meeting the population we think we're meeting? And we want to be able to demonstrate accountability to the people we are serving, to our program leadership, and to our donors. And they wanted to know, are we reaching our target audience? And how do we compare to ourselves over time? Are we improving our clinic over time? How do we compare to our peer organizations? And how do we compare to national results? So this is our challenge of what we want to be able to do with routine data collection that's meaningful for management. So there's several different ways that you can measure poverty. You can look at income. You can ask someone, how much money do you make? This can be challenging, especially in low and middle income countries, because income can fluctuate. If you have someone who is ill and can't work for several months, that can substantially impact both the money that you spent on healthcare, but also the money that's coming into your family. It's hard to put a value on things like bartering for services or trading for services. So income can be used, but it can be a bit difficult. You might use something like the Progress Out of Poverty Index, and some of you may have heard of this. It's a set of 10 country-specific questions that's compiled from a variety of different data sources that gives you a probability that someone lives above or below a given poverty line. You might use community participatory methods. So that means you bring a community together and you say, what does it mean to be wealthy or poor in this community? And then you evaluate based on what the community has decided is most important. You may use something like the Multidimensional Poverty Index, which is an index that looks at a variety of factors related to standard of living, access to education, health, and looks at someone who is multidimensionally poor. Or you might use something like the Wealth Index. The Wealth Index is supported by USAID, and it gives a relative wealth. It looks at things that you own, and it looks at characteristics of your house. So you might use some of these different tools to look at the wealth of your clients. So I want to emphasize our end user's perspective in this, because when you're thinking about who is going to use your data, you have to think about why do they want it, who is using it, what is their perspective. So we're looking at NGOs providing clinic-based services. So we're thinking about someone coming to you to receive services, and that's important to keep in mind as we go through this example. So from that perspective, we looked at 3 commonly used methods: the Progress Out of Poverty Index, the Wealth Index, and the Multidimensional Poverty Index. And in that initial look, we dismissed the MPI because we said it has subjective weighting, and it can be kind of difficult to interpret when you're thinking about making program decisions from that. And so we looked more in depth at the Wealth Index and the Progress Out of Poverty Index. So from our clinic's perspective, of someone coming to your NGO for clinic services, the priorities were it needed to be easy to collect and interpret. It couldn't cost a lot because we know that programs working in low and middle income countries often have fairly limited and restricted budgets. And so it had to be low cost. They wanted it to be comparable to a national context so that you could compare it to what's happening in your country, and something that you could compare across countries. And so we looked at the Wealth Index and the PPI and said, they both do a lot of really great things, but neither of them fully satisfies all of the criteria for our NGOs. The Wealth Index is difficult to calculate. It requires a fairly sophisticated level of statistical knowledge and the ability to run a principal components analysis. And the questions are long and they're time consuming. On the other hand, the Progress Out of Poverty Index can be difficult to interpret, this percentage of probability someone lives above or below a poverty line. And the upkeep costs and the cost to add new countries were rather substantial. So we said, well, neither of them does it all, so let's figure out which one is better for our end users' perspective of NGOs providing clinic-based services. So in 2012, we did a pilot in 5 countries, and through exit interviews, asked all of the questions in the Progress Out of Poverty Index and all of the questions in the Wealth Index. And we took these results back to program managers and got their feedback and said, what did you think about using these and the results that you got from them? And they're both feasible, was the feedback. They're both feasible. But ultimately, we picked the Wealth Index for a couple of reasons. One, it has some context baked into your program. So you get this idea of relative wealth, where this idea of interpreting the percentage, there's a 65% chance that this person lives above $1.25 a day, or $1.90, was difficult. The high upkeep costs was a challenge for a lot of the programs. And the Wealth Index had better transparency. So it's something that we could recreate ourselves based on data that DHS, that's the USAID program, releases. Whereas the Progress Out of Poverty Index is a proprietary method. And so you have to go to the foundation and now the organization that supports it. So what does it do? It's part of the Demographic and Health Survey that's conducted about every 5 years. And it gives you a relative measure of wealth based on things you own, like a radio or a bicycle or an armoire, and characteristics of your home, like what the floor is made of or what the walls are made of. And it divides the population into quintiles so that you can look at results in relationship to these quintiles of wealth. So you can look at disease profile based on your relative wealth of being poor or wealthy in that country, or client satisfaction. Various different aspects you might be interested in. Let's back up. Make sure, what are quintiles? If you took the entire population of a country and you asked them these questions about what they own and the characteristics of their home, and you line them up from the poorest to the wealthiest. And I want to mention that when I'm talking wealthy, I'm talking relatively wealthy. So this could be a country where everyone is still living below $3.10 a day, or whatever the line is. So this is a relative measure. So just be cognizant when I'm talking about wealth that I'm not talking about wealth as we would here in the United States. So you take everyone and you line them up from the poorest to the wealthiest, and you divide them into 5 equal groups, or the quintiles. So quintile 1 is the lowest quintile. Those would relatively be the poorest in your country. Quintile 5 is the wealthiest, and so you have 20% of the population in each group. And then you can ask these same sets of questions to someone who comes into your clinic, and you can compare them to those national results and see what the distribution of wealth is within your clinic. So in this example, 30% of these people are in the lowest wealth quintile, and only 10% in the wealthiest wealth quintile, quintile 5. So now we're going to do a little participation so that you can see what it's like to use this wealth index that we ultimately picked. So if I can get 2 volunteers, I need one person, maybe 3. One person who would be willing to be our interviewee, and the good news is that every answer you get is correct. So I can get somebody who would volunteer to be our interviewee for this. Great, you want to come up? And then can I get 2 people to pass these out? This is a copy of an example of what a wealth index looks like as part of the Demographic and Health Survey. So what I'll have you do is score along with us, so you can get this example of what it looks like to score. And great. So do you want to come on up to the front of the room? Oh, and can I have one question?
Oh, okay. I think
Great. So as we're passing those out, let me set up the scenario for you. You're a program manager in rural Benin, which we have up here on the map. You're running an agricultural program to teach poor women how to grow healthy food. They make a modest contribution to participate in your program, and the idea is that you'll teach them how to grow healthy food to use for their family to increase nutrition, as well as to be able to sell the extra. So we're working on economic benefit as well. And the assumption that you've made is that you're based in a rural location, and so you're serving the poor. So we know that those living in a rural location tend to be more poor than those living in an urban location. What we want to know, are we meeting our mission? So our friend here has come into our clinic for services. So remember, he's come to us. And we're going to go through these questions to determine what wealth quintile he's in. Great. So I'm going to start by asking you. You don't need to have one.
Okay.
We don't know your literacy level, so I'm going to administer the questions.
Okay.
So what kind of toilet do members of your household use? This is your toilet. So we can all see this now, but remember, you don't know this when he comes into your clinic. Is it flushed to pipe sewer system? Is it flushed to septic tank? Flushed to pit latrine? Flushed to somewhere else? Flushed to you don't know where? Is it ventilated and improved pit latrine? A pit latrine with a slab? A pit latrine with an open pit? A composting toilet? A bucket toilet? A hanging toilet or hanging latrine? Or do you have no facility, you use bush or field, or is it something else?
So I assume what? I'm from that area?
That's your toilet. What type of toilet is that from all those choices I just gave you?
Well, it's kind of... I don't remember all those choices. There were tons of them. So long to me.
Sure.
To be honest.
So that's our first example. This is why this can be difficult.
Yeah.
So you're going to try and score this based on how would you describe your toilet?
It's bad.
Does it have walls?
It has walls, a roof. I'm from third world, so I can relate to it. But coming from that part of the world, yes, it's not all that bad. It still has some privacy to offer. A door which hopefully locks, and a hole which is there, which is not exposing excreta to the exterior. So it's okay.
Great, thank you. So all of you can score. What type of toilet do you have? Do you share this facility with other households?
Yes.
How many households use this facility?
On an average, like let's say 6.
6. Great. Does your household have electricity?
No.
A radio?
Yes.
A television?
No.
A mobile phone?
Yes.
A non-mobile phone?
No.
A refrigerator?
No.
An almirah or a wardrobe?
Yes.
A table?
Yes.
A chair?
Yes.
An electric fan?
No.
A DVD or VCD player?
No.
A water pump?
No.
What type of fuel does your household mainly use for cooking? Is it electricity, LPG, natural gas, biogas, kerosene, coal, lignite, charcoal, wood, straw, shrubs, and grass, agricultural crops, animal dung, or no food is cooked in this house, or is it something else?
Wood, kerosene oil.
Kerosene? Now we're moving on to the next one. And we're going to skip, for the purposes of this, down to question 115. What is the main material of your roof? This is your home. You have no roof. Use thatch, palm leaves, palm, and bamboo, wood planks, cardboard, tin, wood, ceramic tiles, cement, roofing shingles, or something else.
Roof with palm leaves.
Palm leaves? Thank you. And then we'll move to the next question of 116. The main material of the exterior walls. You have no walls, cane, palm, trunks, dirt. You have bamboo with mud, stone with mud, plywood, cardboard, tin, cement, stone with lime and cement, bricks, wood planks, shingles, or something else.
Mud.
Great. And you'll see there's still more questions that we could go through. We still have a page and a half of questions, but I think you get the example of what it's like to use the wealth index and to be able to record your observations. So thank you very much. You can have a seat. All right, so you've all now surveyed, you've done a representative sample of those in your clinic, and you want to know, are we serving the poor? So how are we going to get these results? What are we going to have to do? Well, you all have paper surveys, so we're going to have to collect them. There can be a lot of them. You have to take them to headquarters. You have to complete the data entry. Then you have to share that database with an analyst who's going to review and clean the data, calculate the scores using a principal components analysis, write a report, and give it to the decision makers. This can take a fair bit of time. So we are working with a program that is doing another set of data collection, and they did 200 surveys at the beginning of December. And it's now the beginning of February, so we're two and a half months into this project. and they have entered 80 of the surveys. So this takes time, and that's just the first step of completing the data entry. And we recognize that in using this wealth index, challenges remain. The questions are long and complicated with a lot of different response options. Respondents may not know. So I'm guessing that some of you might have scored the toilet question differently based on how he described his toilet. Or if you imagine a 17-year-old girl coming into your clinic for family planning services, and you ask her, how many hectares of land do your parents own? First of all, can anyone in this room define a hectare of land for me? So she may not know. She may not know how to answer that question. So it becomes difficult. And we also recognize that those data analysis challenges are real. Being able to have the on-site staff and the software to run a PCA, a principal components analysis, can be challenging. And so we started thinking, is there a way that we can make this easier, that we can simplify the data to make it meaningful and useful for program managers? But yes, we can do this. And so we did a preliminary analysis of 16 countries. And we looked at 4 different alternatives and compared those against asking all of the questions in the demographic and health wealth survey. And then compared how well that agreed to that full set of questions. So what these analyses did was we looked at questions in different groups. We looked at variables that are asked in all demographic and health surveys. And then we looked at questions that are country-specific, questions that address land ownership, questions that address animal ownership, and questions that look at living in an urban and rural residence. So the full wealth index is going to ask questions about all of these things. And in our alternatives, we looked at different combinations. So for example, in this first one, anything that was country-specific, we took out of our analysis. And then we would run our data again and see how well it compared to asking the full set of wealth index questions. And we did a variety of different combinations with the other analyses. And then we took this back to our expert panel and reviewed and discussed, and they said, yeah, that's really interesting, and that was a good academic exercise, but from a program management perspective, that's not useful. Ugh. So do it again. Do a 5th one, and you need to prioritize making this easy for a respondent to answer, which means it's also easier for someone to administer the survey. It needs to have utility in urban settings, meaning we know that those living in urban areas tend to be wealthier. So we want to, if a clinic is based solely in an urban area, we want to know, are we serving the urban poor, which would generally be wealthier than a rural poor. And it has to have a high level of agreement with the full demographic and health wealth survey. So this kappa statistic of 0.75 means that it has a high level of agreement with the full. So we ran this again. We took out those questions that are difficult about land ownership and animal ownership. We kept the questions that are specific to the countries. And we kept the questions that can help distinguish between that urban and rural residents. And we presented it back, and they said, yes, this will work. This is good. And so through that, we're able to shorten the wealth index on average by about 2/3. So we can decrease the number of questions. For example, in Cameroon, we can go from 47 down to 9. And we can also decrease the number of variables. So all of those different answer choices we can substantially decrease. So what that means is you're looking at a question in French from Benin about the type of cooking fuel you would use. This is what it looks like in the full DHS. And in our simplification, this is what it looks like. We're just asking wood or other, and that's enough that we can make these distinctions. And then we put all of that, as a good Silicon Valley NGO would do, we put all of that into a mobile application called the Equity Tool. And it is a set of simplified questions that's country specific. It works online or offline, so you just have to connect once. It will automate and calculate your results for you, so you don't have to be able to run a principal components analysis to get your results. It can be done in real time, and it's free. So we're going to go through this again. If you are sitting on this half of the room when we do the survey, you're all going to be survey respondents. So this half, I want you to imagine that you're relatively wealthy. And if you're sitting on this half of the room, I want you to imagine that you're relatively poor. And this is the fun part where few speakers will probably say this to you, but please get out your phones, or your computers, or your tablets, and go to this web address. What it's going to do is take you to a survey for men. It's going to come up in French, because they always come up in the native language. If you want to take it in French, great, go ahead and do that. If you don't want to take it in French, up in the upper right corner, you'll be able to, there's a drop down where you can change your language. So you can change it to English if you prefer to look at the questions in English. Go through, take the questions, answer them however you'd like, again imagining this half is relatively wealthy, this half is relatively poor. And when you're done, you'll hit submit. Because you're all connected to the internet right now, it's going to then automatically load a new survey for you. So you could do this over and over. If you could just do it once, that would be great for the purposes of example. But when you're a survey administrator, it would then allow you to go on to the next person that you're interviewing. And again, it works whether you're connected to the internet or not. It will just queue those results until the next time you connect, and then it will go up. So has everyone had a chance to see this address? Great. So we're doing the same scenario. You're a program manager with this agricultural program where you're teaching women how to grow healthy food for themselves and to sell. And you want to know, are we actually reaching the poor? We're going to look at some real-time results. Can everyone see this? Is this large enough? So we're looking at this example. This is in my administration account of what this would look like. We had 68 submissions, but now that you've all participated, I'm going to sync the data, and we have 82. So we're getting this data in real time. And then we're going to look at our report. I also have to say, you all are very tech savvy. I've done this in other audiences, and we have struggled. So we know we interviewed 84 recipients, and these are our results. So it's automatically calculating. So it takes out all of that analysis that you would have to do. And we're seeing that 62% of our population that we interviewed is in quintile 5, the wealthiest quintile. And our program was aiming to serve the poor. So that's quintiles 1 and 2. Okay, well, we know this now. So we can get these results. And I'm looking at national results because I said we're in an urban area or a rural area, but you can also compare how the results would be slightly different if you're looking at the urban poor. So in this example, 42% are in the wealthiest quintile compared to our 62% compared across everyone in the country. So that's why it can be helpful to be able to make those distinctions between the urban and the rural. This can be done in other programs. You don't have to use this online. Some people have a data collection tool that they're already really happy with and satisfied with, or you want to ask additional questions. You can add questions to this online version if you wanted to get demographic information or ask other questions pertinent to your program. So you can do it that way, or we're equally happy to share the questions and the quintile cutoffs and analysis guidelines and data and SPSS and Excel code so that you can run these analyses on your own. And this is an example from a program that we actually worked with. This is from Helen Keller International, who did this in Cambodia. And they did 4,500 surveys in 2 weeks, compared to the amount of time that the AME program took. They were able to do this with existing program staff in a very short amount of time for very low cost. And they got this data back, and they found out that they weren't reaching who they thought they were reaching. And so they started asking some questions. If we're not reaching the poor, who is participating in our program? We're based in a rural area, but we're serving wealthy clients. Why would that be? Does anyone have any thoughts about why that might be?
The whole concept is which sample you are picking up by this survey.
So theoretically, you're going to use a representative sample, so that shouldn't be a problem. But yes, sample size can absolutely be the sample that you're using can absolutely influence your results. So you do want to make sure it's representative. So if we assume it's representative, some of the things that this program thought about is there's a financial contribution to participate. Even though it's modest, there is still a financial contribution to participate. And you have to own land. So that can influence potentially who can even participate in the program to start. I want to know, how can we reach the lowest 2 quintiles? If that's their goal, which is a common goal, the World Bank aims to serve the poorest 40% of the population. It's a core component of universal health coverage. A variety of different programs are aiming to serve the poor. So if we're trying to serve those poorest 2 quintiles, should we get rid of that financial contribution? Should we say we recognize that this is a barrier and we can't have a financial contribution? But if we do that, can we sustain our clinic operations? Are we going to be wholly donor dependent if we don't have participants making some sort of contribution? And what other adjustments should we make to our program model? So what we did today was we looked at some examples that demonstrate the importance of data for program management. We looked at an example from our work to discuss to measure client poverty, introduced you to the equity tool as one option for data for managers. And I hope that you'll walk away with this thinking about how data can transform health service delivery. And that routine and actionable data is really important to make these evidence-based decisions. And that it doesn't have to be time-consuming, it doesn't have to be expensive, it doesn't have to be a strictly academic exercise, or because someone else said that you need to collect this data. That can be really meaningful for you as how you're delivering services. I always want to recognize our collaborators in this project. We worked with a variety of different organizations to create this tool, to test it, and to produce it. So I want to recognize all of our collaborators who have been part of putting this together. And then I'll open it up for a few questions. I'm going to have questions where I can go into more details on of how the methodology, if anyone's interested in that. Yeah.
Did you say how you manage the language issue? Did you train local surveys, national surveys?
You mean to administer it or to translate the files?
Both.
Both. Good questions. So my first degree is in translation, so I'm very passionate about the translation questions. We use professional translators to translate it, with the caveat that when it already exists in another language in a USAID program, so a lot of times like the French will only be in French, already in French, and so we'll use the language that they've already approved and tested, and then we'll translate any missing pieces. Or if it hasn't been translated before, then we'll use a professional translator and editor team to be able to translate it. And then you usually are working with in-country survey data collection teams. So it's usually people who have a given level of education, and then they'll be trained before a program to be able to go out and administer the surveys in the language that you choose. Yeah.
If you're in a rural area abroad where there isn't any internet, is there a physical version, or how do you navigate that?
Yeah, so there's a couple of different ways you can approach that. One is if you really like the equity tool online version, that's great. You can still use it. The idea is that you connect to the internet once, and then that's all you have to do. Then you can go and do the survey as many times as you want offline, and then the next time that you come back to headquarters to connect to the internet again, it'll automatically sync that data. So it just gets stored locally in your browser. Alternatively, we've had organizations do this paper-based. Organizations who have incorporated this into their own tablet-based system. There's a variety of different ways that you can then take the same questions and still calculate the results. And we've worked to make that easy. So you can use it online, you can use this online tool, the equity tool, or you can incorporate it other ways, but it will work online and offline. Yeah.
So this is a free tool.
It is free.
How long would it take, to customize it to your specific projects, your specific country and language? How long does that process take? For example, if someone had a project this summer in East Africa, say that to me.
For instance, yes. So we have it available in over 30 countries right now, and that's based on places where there's been a recent DHS. It really will depend on your program and how many questions you want to answer. The back end of this is supported by Kobo Toolbox, which is out of the Harvard Humanitarian Initiative. So they're thinking about people who are doing surveys. So if you like this online version, you like the data collection automated, you like having your results automated, you can add your own questions, and it has the same sort of skip logic and ability to add questions or calculate. And then you can just download your data as an Excel file or various different formats from the back end. So if you like that version, you can do it. Otherwise, it usually ranges between 6 and 15 questions or so for if you wanted to just take these questions about client wealth and incorporate them into whatever format you're using. So it's pretty easy, and I'd be happy to chat with you more about how you can do that after. So, yeah.
Are there versions for U.S.-based programs, or are they all for?
It's all for low and middle income countries. A lot of times in the U.S., you can ask that income question because it tends to be more accurate, and since we're reporting for things like taxes, or we can make some pretty good estimates based on other social services available. So the utility is for low and middle income countries, and that also is because that's where demographic and health surveys are done by USAID. So the focus is really low and middle income countries.
One of the issues with these grants is that people who are assessing those third world countries from developed world, they land in those cities which have airport means, they are big cities, and they try to pick up rural areas which are probably near. That's what ease of data collection.
Convenience.
Coming from that part of the world, I very clearly understand that it's not the true representative of that country. I'm from Pakistan. If you land in Islamabad, you think, oh, probably this is the most beautiful city in the world. But that is not what reality is, 80%. So how do you overcome that? Because my personal experience, a physician working after primary care in Pakistan, that entire system failed across the country because somebody did research, landing in Islamabad and adjoining area, got that program implemented across the country, failed, miserably failed. So how do you overcome this common problem?
Yeah, it's USAID. So when they do these demographic and health surveys, they're doing a national sample and a nationally representative sample. So they're going out into those rural areas and collecting the data. And so what you're comparing to when you would do something like this within your own program is what does my program look like compared to the entire country. So you are comparing to a national sample, and then you can see if I'm in Islamabad, perhaps we tend to be serving wealthier people because of the nature of being in a city versus going out to a rural area. So you can still get the same results because you're comparing to a nationally representative sample. Does that answer the question?
Yeah, okay. I haven't seen that really happening because they come up with 10 billboards, and because the masses or the target population do not get those benefits. You need local human resource to get the things done. Obviously, how many people you can fly in from, right? Maybe 5, maybe 10, but then you need a whole team, big team. They mostly work in collaboration with non-profit organizations. They are working there. And that is where 70% of the dollars they get into administrative stuff, and what is really left behind for actual action is 30%. And that also goes into the wrong target population.
Sure. Access is always a challenge. I think this is something that our founder saw in programs that he started running in Vietnam, is that they would build wells along the road because it was easy to build a well along a road. And so you could easily get the equipment there, you could build it, you could measure it, you could check it. But that wasn't actually where it was really needed. So I think that's a really good point, that a lot of times we might be measuring how we're providing services for a population and not ever actually reaching that rural population that's most in need, or that sort of some of the urban hidden populations that don't ever access services. So that's a point that we always have to keep in mind when we work in global health. I'm happy to chat with anyone about specific projects that you're doing. We do offer technical assistance for programs, help you to be able to use data to measure your performance. So happy to chat with anyone or answer any more technical questions. If you're interested in the details, we have a journal article if you want to look at this in Global Health Science and Practice. We work to make our work very transparent, so you can go to our website, the Equity Tool website, and you can get the fact sheets for all of the countries. You can see how it was created, any sorts of challenges in creating the index. Or if you wanted to, you can read this paper and do it yourself. It's free though, so unless you're really excited about running PCAs. you can just use the free version. And it looks like we're a little bit early, so you'll have a little bit of an extra break now in transitioning to your next session.
Alrighty, so next will be the panels, and after that, just so you guys know, lunch will be provided on this floor, and we'll be having the community fair again where you all registered. So feel free to check that out after.
Hi.
Thank you. That was great.
Oh my gosh, hi. I did that.
Wait.
How are you? Sorry, I'm like.